And now it's my pleasure to introduce Dr. Funke.
Good morning.
Dr. Funke is a fellowship-trained glaucoma specialist who enjoys caring for a multitude of eye conditions, including glaucoma, cataracts, diabetes, dry eye, and routine eye care. She grew up in the western suburbs of Chicago and studied biology at the University of Notre Dame. After undergrad, she earned her medical degree at Rush Medical College and completed her residency in Cleveland, Ohio. Dr. Funke specializes in state-of-the-art minimally invasive glaucoma surgery, trabeculectomies, tube implants, glaucoma laser surgery, complicated cataract surgery, and combined cataract glaucoma surgery. Dr. Funke, welcome.
Thank you. Nice to be here. Good morning, everybody. See all that? Let me get my face off of this page there. Good. So again, I'm Christine. Nice to meet everyone. And yes, I am a glaucoma specialist. And it's also really a huge passion of mine talking about minimally invasives, which is what we're going to all talk about together. Financial disclosures, I do work with Alcon, Sight Sciences, also Glaukos and Elios, which aren't on there. Questions, you can email me. Please feel free. I know that there's a lot of devices out there and a lot of changes that keep coming, and especially in this space, which is what makes me so excited. So if anyone ever needs anything from me in terms of cases or just general questions, again, feel free. I'm always open. And so today, the discussion that we're going to have is minimally invasive glaucoma surgery. I've already talked about that. Before we get into it, just kind of my background around MIGS. I've been doing MIGS since right after I came out of fellowship in 2015, and that's when MIGS was really born. So when I went into glaucoma, everything that we really learned was trabs and tubes. So this is near and dear to my heart because I think minimally invasives have really changed how I function as a surgeon, and then also how we can treat patients. So when I talk about kind of our goals together, I think one is getting you guys comfortable with what's out there in terms of the market, feeling comfortable that they actually work, because I know that when we first started, right, we only had a single device and we are still learning and growing as a community. And I think there's so many more options now available, and we've gotten a lot better at taking care of people with these minimally invasives. And I just want you to also feel comfortable with just the terminology. So there's a lot of different things out there. Some of them are just different device names, but they go into the same broad category of different surgeries. So I want to make sure everyone knows, you know, what each of these devices are and kind of what category they fit into. So anatomy review, so forgive me, probably boring, but for me, this is probably one of the most important things that I look at every day, both clinically as well as surgically, is looking at the angle, right? If the angle is open and beautiful, I know that I'm going to have a much better success when it comes to doing my surgeries. And so I'm looking for all these different places in order to know where my MIGS are going to go. But for you, when you're meeting your patients and talking to them, this is really helpful. If you feel comfortable with gonioscopy, then you can tell me as a surgeon, like, this is a beautiful, open, wonderful angle. This is a great person who can go on to minimally invasives. And then also post-op, another important thing is you can see if I did my job right? So you can look and make sure that this is in the correct position. So for me, you should be seeing most of my devices sitting right inside the trabecular meshwork for any bypasses or if I'm working inside of the canal. And then for any Zens, you're going to see it sitting usually right above or right at the canal area. So again, both of us, it's all an important thing. And then also, again, if you're seeing other changes, synechial changes, etc., it's another nice thing to know about because, again, it may change what your thought process is and then what my thought process is in terms of what minimally invasives might work best for these individuals. So why minimally invasives? I think this is probably not the hardest question to ask, but for me, of course, they work in lowering pressure. Again, we have gotten better and better as we've gotten further on in using these devices. They can be done ab interno or ab externo. The vast majority of what I do is ab interno with an occasional ab externo, which is mostly Zen, which we'll get to. And then obviously also limited manipulation of the external part of the globe, which for me is important because I'm saving that for later down the line, right? I no longer just go straight and jump into a trab or a tube, but we've got now a nice stopgap that we can prevent those bigger surgeries. And as all of you know, people who are status post trab and status post tube, there's a lot of other issues, which we're avoiding when we look at minimally invasives. But the big ones being Contact lens wear becomes a huge problem for patients. Surface disease can also be a huge problem that we're trying to avoid with using these with trabs and tubes. And that's not even talking about all the medication complications too. Safety, another huge factor, right? So again, when we're talking about all the previous surgeries that all of us as glaucoma surgeons have been doing, a lot of it almost feels antiquated at this point because we did these very large surgeries, hard to recover from, usually months. We have risk of leaks, exposures, etc. And all of these devices was then being excluded, which I kind of put into the like moderately invasive glaucoma surgery. But all the other things where we're working in the angle, we don't have any worries there, right? We don't have these issues of exposure. And then also just generally, we don't see as much hypotony. There's minimal amounts of bleeding. Really, the amount of times where we have any vision loss related to minimally invasives is next to nothing. So when I look at the complication rates, typically for tubes and trabs nationally at like 20 to 30%, and then I look at my minimally invasives, which I consider just as similar in terms of their rate of any complications to cataract surgery alone, it's a huge shift. So for me, again, so important. There's less hand-holding. I do a lot more co-management because it's an easy co-management thing to do as opposed to the tubes and trabs, which I kind of feel like I'm marrying these patients when I do these surgeries. So that's a nice thing. One negative is long-term data. There's not as much long-term data. I can't say not available anymore. There's some good long-term data in terms of HYDRUS, which I'll show you as well. But that's compared to tubes and trabs, which have been around for decades. So we have a lot more to discuss in terms of longevity, that these are just newer. So we just don't have that yet, but it'll come. And then there's not going to probably ever be any randomized studies looking at minimally invasives versus traditional surgery. And that's because we know that traditional surgery is a lot more aggressive. Pressures are going to come way down, way faster. And so I don't think any pharma company would ever want to look at those studies. So that's why we probably won't see those. And then, of course, surgical time, much quicker. Recovery time is also going to be much quicker. We don't have incisions that are large. We don't have stitches, all those things. So safety-wise, we're doing much better there. And then one thing also is, of course, you're not going to see the same pressure drops as you would with traditional surgery. Don't look at that. But this is all the different devices that are out there. So just know, again, if you're overwhelmed by the idea of MIGS, you're not alone. There's just so many devices. This is a super hot space, which is fun for me as a surgeon, but sometimes, again, can be overwhelming for people who don't work with somebody like me on a daily basis. So we're going to go through all of them, starting with the first one that came out, which is iStent. I'm assuming everybody's probably pretty familiar at this point with iStent. iStent and iStent Inject, which was the next iteration. And when we're talking about this, it's a trabecular meshwork bypass, right? So we are going from getting fluid to bypass the TM, which we know is where usually the blockade is for most open angle glaucoma, and we're going straight into the canal. So we're trying to bring extra fluid in there. And when we look at when we can use it. So it's always nice to know what patients are candidates for these procedures, only in combination with cataract surgery for iStent and iStent Inject. And for only mild to moderate open angle glaucoma patients. So that's going to be kind of the range of what you're going to be looking at for when we're using these. For these patients, when we looked at the iStent data at 12 months, we had 68% of patients who were medication free. And then that was versus 50% with cataract surgery alone. My caveat always being, we know cataract surgery works really well for glaucoma. Cataract surgery was probably one of the best inventions, phaco specifically, when it comes to treating glaucoma. So we know that just cataract surgery in and of itself does a great job at bringing pressure down, but the combination with the minimally invasives does increase or amplify how well we're seeing those pressure drops. And it also seems to sustain it longer. We tend to find that people who have glaucoma surgery with cataract surgery, we're finding years that they're keeping a pretty nice level of IOP, as opposed to with just the cataract surgery, we tend to find after about 2 years, that effect starts to decrease. Contraindications, of course, being anybody who's not open, right? So anybody who's angle closure, neovascular, Anything else that's unusual about the angle. So again, why you want to go and peek at the angle so you can know how open the angle is. If it's mildly narrow, that wouldn't be a contraindication in my world, because we know once the cataract is out, that angle is going to open up much more significantly. And so I'm going to have a much better access into that area. And then again, adverse events, generally, I think this is a nice list for most minimally invasives that we're looking at, maybe a little bit of edema. But again, this is to me, very similar to what I see post-op for just a straight cataract. Some vision loss, maybe. PCO, I don't know if it's any more extensive than what you would see in a normal cataract surgery. Stent obstruction is a true thing. I do tend to find that I see this a little bit more commonly in the smaller stents than I do in the larger stents. So you can see sometimes that you'll actually see a little endothelial sheen or layer that can sometimes go over the stent. Sometimes you can also see iris tissue come up and synechate over the stent as well. So those can happen, but it's not that often, as long as it's well placed. And then a little bit of extra AC reaction can happen. I do see a little bit more rebound iritis with some of my MIGS patients, because again, it's more surgery. So don't be afraid to just treat them a little bit longer with steroid as needed. And then I think corneal abrasion probably just happened in the study. So here's some nice other data around the iStent inject with their pivotal trials. The first graph is looking at anybody who had greater than 20% reduction in their IOP post. And this is looking both with the green graph at the iStent inject with phaco and then the blue with phaco alone. And so you can see there was an obvious reduction that was much more significant in that first year with the iStent inject. And then also looking at average pressure drop, the average pressure drop of 7 millimeters of mercury with the iStent inject plus phaco versus phaco alone. But again, you can see how well phaco did just on its own. iStent Infinite. So this is the newer stent. So I don't know how many people have seen this guy. I just started using it in the OR probably within the last month. This is the first bypass that we can use as a standalone product. So we do not need cataract surgery in conjunction with iStent inject. So 3 stents now instead of 2 with the most recent W, and then the single stent was the first thing we had. So we've gone up to 3. The other difference in how this is made is that you can see now, instead of just an opening at the front and the back of the stent, but you also have some ports or openings around the side of the hub. And that little hub is actually going into the canal and bypassing. And so what's nice about that is a lot of these canals are sick, there's herniations, and there's other issues. So with the original stents, my concern always was that I was just going to push it in and then hit the back of the wall, and then it's just obstructed on the other end. And then what am I doing? So this, they've made a nicer change there. And I think that makes a little bit more sense to have those extra holes on the side so that you're getting a little extra full flow. So, even if you're obstructing in the back, you're still actually getting some good flow there otherwise. Infinite has a little bit of a hurdle to get through to get into the eye for patients. So there's a couple rules associated with what the FDA has approved this for. The big ones being uncontrolled on medication, and that can be use multiple medications, they didn't work, or also that the surface isn't good. So I'm sure all of you have seen a lot of bad surface in glaucoma patients. I know I do every day. And so one of my big thoughts when it comes to using minimally invasives, not only is it to increase compliance, right? Because once I get the stent in there, then we're good to go. And people aren't great at medications, but also surface disease gets a lot better. So a lot of patients post-operatively, once they've gotten their minimally invasives, their cataract or without, the amount of patients who are happy that their eyes actually feel better is pretty incredible. And it's very gratifying, both to me and then also to all of you guys. So non-adherence or non-compliance can also be in that list of not working well with the medication. Intolerance for any reason. And then you also have to have a failed surgical procedure. So that's the second thing. So you have to have, usually it has to be 2 meds that they've failed on, or just allergy to all, and then also failed surgical procedure. That can be as simple as an SLT. And then also maybe you can say they failed phaco. That one's a little harder. But that may be a possibility as well, depending on how everything else is looking, that you can argue that. But also TRABs, you can look at tubes. I've done a lot of minimally invasives after people have had a larger glaucoma surgery because already the conjunctiva is kind of taken up. I'm not the biggest fan of inferior tubes. They have a lot of risk of failure and exposure. So this is another nice option. And their clinical data looked really good. So looking again at that save 12-month period, you're seeing something similar with the results of a little over 70% with a 20% reduction and close to 50% with 30% reduction, which is really good for these, 3 very small stents into the canal. And the mean pressure was around 17, also very similar to the previous studies. And the big one for me is at the bottom, which is about 5% of people needing to go on to a secondary surgery, that meaning usually tubes or trabs. So this is really saving a lot of people from having to go on to bigger stuff. Next is the HYDRUS. So again, we're talking still in the bypass category. So with this one, this is another bypass, but much larger. HYDRUS is got a couple different mechanisms of action that happen at the same time. So we're already bypassing the meshwork, which is great. But what the other thing that I love about HYDRUS is also dilating the canal. So you're doing multiple things at once. So if you look at this picture image of the HYDRUS, on the far left, you can see the head of the HYDRUS. So it's a larger opening. So you're getting extra fluid flowing into the canal. But then as you look further downstream, you can see these little windows or openings, and those are actually dilating and opening the canal. So I always, when I talk to patients about using HYDRUS, which I use very commonly in my practice, I talk to them about cardiac surgery. And I say that we're trying to open things up and stent things and keep things open. It is inert, so it's nothing that patients have to be worried about in terms of what it was made of. And this is also an indication of cataract surgery only for mild or moderate glaucoma, open angle. So similar kind of constraints on who can get this device. And then for HYDRUS, HYDRUS has a longer study length of time that they were looking at HYDRUS. Now they've looked at it for over 5 years and watching how patients have done. And it's done really well at keeping pressures low and staying in a lower bracket, which is great to see. Initially, patients were getting about 77% reduction in 77% of patients were getting reduction in pressure of under 20%, compared to the cataract surgery alone, which is similar to about something around 50%. And I find that very commonly in my practice. So this isn't something where I feel like the data doesn't get supported clinically. I think that they are very well meshed and that it works really well. There was also a study done by Ike Ahmed, which I think is interesting, looking at HYDRUS versus iStent. This is definitely not something that probably was supported by either company, right? But he probably did on his own. And this is called the COMPARE study. And this was looking at standalone treatment. So that's the other interesting part of this. This was not in conjunction with cataract surgery. So just looking at how these two did on their own as a device. And he did show that at 12-month period of time, there was a difference with HYDRUS having greater surgical success at getting pressures lower. So it's kind of a nice head-to-head data that is going to be hard to find otherwise. And the iStent that was being used, that iteration was 2 stents. Also looking at HYDRUS versus SLT, I'm a huge SLT fan. I think it has a great position in taking care of glaucoma, again, limiting how much medication we're getting in people's eyes. And with the light study coming, we know that that's really a great way to go as a first-line therapy, and it works better initially as opposed to after medications are already on. And this is looking at HYDRUS versus SLT. Not surprisingly, the HYDRUS did better at bringing the pressure down at that 12-month period of time, but SLT still didn't do a bad job. So again, for initial treatment, when you're looking at something to try and avoid medication, it's a really nice way to go. And then this is that quick look at that 5-year data for HYDRUS with Horizon, and showing that one really important thing is it was looking at the amount of loss in terms of visual field loss, and finding that there was a 40% reduction in the amount of patients who are having further damage to their field. So that's excellent. It's showing that it's working, because sometimes we'll see patients who are under good control with their pressure, but they're still advancing. And we know that surgically, for some reason, you don't have that same swing in the diurnal curve when you do surgical or laser intervention compared to drop intervention. And whether that's partly a compliance issue that we don't know about, or if that's really just because of mechanics, that I don't know. But I think that that's probably one of the reasons that we see such a nice reduction in people having worsening of their disease. For mild patients or single med patients, 73% of patients remained med-free at 5 years. That is awesome data. And that's data I tell my patients all the time, because finally we're getting to a place where we know that at least for 5 years, the vast majority of my patients are off of that single med. So when I initially was doing minimally invasives, I was saving HYDRUS for something probably more moderate glaucoma, and I'm not anymore. So I'm really starting to use it for most of my mild patients single med. And I have found again that this is pretty accurate, that I'm getting most people off. As a caveat, for those of you who are doing shared care with one of your surgeons, know that for any of my glaucoma patients, it's really nice to give them a good 2 months post-op before you really know or gauge how well their minimally invasives have done. And the reason is because by about one day, who knows what their pressure is going to be. By a week, they're starting to have steroid response for a vast majority of them, right? And they still have inflammatory issues going on, which can affect the trabecular meshwork. At a month is usually when they peak on their spiking with the steroid. And so really it's not until they're completely washed out at 2 months that I start to see my final numbers. So I tell all my patients pre-op, I'm like, give me 2 months. Your vision will be better in a couple of days, right? Because of the cataract, but give me a couple months until we know how well this worked. And I think that that's a really good way of not only setting expectations, but also it reminds you at 2 months, hey, I should try and get off of the meds again. And you'll be surprised how many patients, if they're sitting like at a 15, you're like, oh, they're pretty good, I'm just going to leave them on the med too. Don't. You'd be surprised how often you take away the medication and the med's not doing much of anything. And so it's good to always give them a little experiment and see. And then the patients are really happy with the results too. And then for this rate, even lower of only 2.5% of patients who needed conversion onto needing a more advanced form of glaucoma treatment surgically, which again, near and dear to my heart, right? Because I don't want to do those if I don't have to. On to the next. So INTERNO canaloplasty. I have a slide later, but I probably should have put it first. Talking about canaloplasty versus goniotomy, I find a lot of people are really confused about what that means. Sometimes you'll see, oh, I just did canaloplasty, or sometimes I did canaloplasty with goniotomy, or sometimes it's just goniotomy. So what is the difference? Canaloplasty is purely cleaning out the drain, okay? So I always tell patients it's like snaking the drain, that's it. I'm going in there, I'm cleaning it out, I'm dilating it with viscoelastic, then I'm out of there, I'm leaving the trabecular meshwork intact, nothing else is getting altered. I personally am a big fan of canaloplasty. I think it works really well, and I'm saving all that tissue so I can do something else later down the line. Then some people like to rip it out. That's goniotomy. Goniotomy is when you're removing the trabecular meshwork by physically removing it. So we'll talk more about those. But INTERNO canaloplasty, 3 different surgical options. So if you hear any of these devices, they would fit into that category. ABIC, STREAMLINE, or OMNI. The OMNI, a little different. ABIC and OMNI, you can do goniotomy with it. So know that you may hear goniotomy with those devices as well. STREAMLINE is canaloplasty only. And surgical candidates for these, this can be just mild to moderate glaucoma. It is finally something we can use by itself. So just like the new triple iStent Infinite, this is the other option that we have available for people who have already had their cataract taken out or don't need their cataract yet. And I use this very commonly in people who just aren't quite controlled. And then I'll get them into the operating room, do a quick, 5-10 minutes that we're in there together, clean out the drain. Maybe I'll do some goniotomy, put in some stents, and then usually it does really well as that combined. Contact lens wear is a great one because right tubes, trabs, we really ruin that option for them. So that's a really nice other positive for this. Bleeding does occur. It's a little less common that I see that for doing canaloplasty alone because I'm making a very small incision. STREAMLINE has the smallest incision. So if there's somebody on multi blood thinners, that's the one I tend to grab towards. But otherwise, I probably use OMNI at this point 95% of the time for my canaloplasties and goniotomies. I used to use ABIC. We just don't have it at AVP at where I work. So, and then here's just real quickly, just what they look like. For OMNI, their data, they were looking at mean reduction of at least 20% in all the eyes that they studied, which was great. And then the number of the amount of pressure drop lowering was a little bit less than looking at the stents. I personally am a big fan of combining these. So I tend to do for most of my patients who are on multi-meds, which I would say is the vast majority of the people who get sent to me, I'm going to do canaloplasty with usually a stent procedure. ABIC, similar idea, except instead of having just a device that's all concise in one handheld module, it's actually you make a separate incision and you thread the catheter wire in through the canal 360 degrees around. This one's slightly different than the Omni. The Omni, when you inject the viscoelastic, there's a set amount of viscoelastic. For this, you can actually adjust it. So that's one nice thing, is that you can actually push a little more viscoelastic through it. And then STREAMLINE is our newest. This is the best picture I could get, sorry. But it's a very small little needle. And you just push the needle into the canal, and then you push a button and it actually pushes viscoelastic out the side of that needle. So with that, that's why it's so nice for people who are on blood thinners. You're really not making an incision. It's so tiny, I can't see it after I come back out. And you usually do multiple incision sites or small injection sites. The only negative here that I can find is that probably you're not getting a 360-degree cleaning that I can do with the other devices, which is why I don't use this quite as often. We already talked about that. And then now we're talking about the other half, right? The goniotomy. So this is the ripping out devices. So of all those devices, Cahook Blade, Scion, which is one of the newer ones that came out from Sight Sciences, and GAT. All of these, we're just stripping out the meshwork. You're gonna have a lot more bleeding with this because there is blood in the area of the canal and there's reflux blood. So just know that if you see a small hyphema day after or even a week after, don't be concerned. That's not surprising. And I tell patients that often. I am a fan of trying to limit blood thinners 3 days in advance of doing these kinds of procedures if patients can, just because I do feel like they have better visual outcome right afterwards. And then Zen. Zen, again, like I said, is kind of my medium and minimally invasive. I wouldn't call it minimally invasive anymore. Zen was originally created as trying to make trabeculectomy without doing a flap and without going and touching the conjunctiva. So originally it was created as an ab interno device. We pretty quickly found, and myself included in that list, of that it really didn't work very well that way. Lots of scarring, getting stuck in tenons. There was a pretty high failure rate. I would say over 50% would fail with ab interno. I still will do it occasionally for those really deep set orbits who are high risk for anything else. I'll go ab interno, but again, not my favorite. So now we go ab externo. So still making a cut down on the conjunctiva. It's pretty small, only a couple millimeters. So it's a really teeny incision, which is nice. So it's pretty comfortable. The other good thing about using a Zen versus traditional trabeculectomy, traditional trabeculectomy surgery, we make a flap, right? And then you remove that flap, which is a partial thickness of the sclera, and then you punch a hole. And that's directly at the limbus. What's nice and different about this is the Zen is small and long. It's about 6 millimeters in length. So when I enter into the eye, it's usually about 2.5 millimeters posterior to the limbus. It's a lot of numbers. And then after that, you get an extra extension though of that Zen. And what's good about that is you're getting a low-lying flat diffuse bleb. So you don't have as much, I still see it, but I don't get as many of those blebs that are sitting concentrated right at the limbus, which have a lot of problems with leak. I see that they're more diffuse, and I feel like then patients are more comfortable. I have less issues with dry eye. I have less risk of, I have less hypotony with these because it's a small tube that's already the specific size that it needs to be. So you don't seem to see the same hypotony issues. And again, I just feel like the blebs look good. I actually had a patient who came to me after Zen surgery that I got a note that was like, Zen failed, you know, needs alternate options, but the pressure was like 10. And I was like, well, I don't know, it looks pretty good, but when I looked at it, it's just so diffuse and low lying, you could hardly tell there was a bleb there. So it was purely because it just didn't look like a normal trap. So either way, it was a fine surgery, but it's just interesting how different these look than what you would consider traditional trabeculectomy to look like. And I think that's a great thing. And again, I find less choroidals and less hypotony and all the other issues that are a nightmare with these patients. The other thing too is that the flap closure is a lot smaller. So that opening into the conjunctiva being so tiny, I use like a 9.0. And so because it's so small, there's not as much issue of the patients being uncomfortable as they're healing post-op. So I don't seem to hear as many like, you know, my eye feels scratchy or irritated. One other big one with these is they really do need a lot of steroid post-op. So we use mitomycin for these patients. The mitomycin helps with preventing scar, but if there's redness and inflammation over that site, it's really nice to just keep hitting it hard with steroids so they don't fail. And I find that now after doing a lot of these and starting to get my technique to where I like it, I feel like I'm still getting probably about 5% scar and failure, and you do have to needle them a lot more. So again, that's one of the negatives versus traditional traps. So good candidates, very honestly, for the most part, anybody open angle, great candidate, anyone uncontrolled. Higher pressures, if they're in the 30s, I'll go for these. If it's going into the 40s, etc., then usually I'm going to do something larger like a barbell. Pseudo exfoliation, pigment dispersion, all of those are on the list. Angle closures are a contraindication. I'll be honest, I've probably done them. But one thing I would avoid is anybody who's neovascular or anybody who's got uveitis, because they'll just fail. And episcleral or venous pressure issues, because if you're going into the conjunctiva, again, it probably won't work. There are studies looking at Zen gel versus Trab. So this is a really nice study so that it can kind of show the positives and negatives of each surgery. The mean pressure on 3 meds, most patients really decreased significantly on the amount of medications that they needed, as well as kept it a pretty good low pressure. I tend to find that true as well for my own patients. Trab groups had more post-op complications. I don't know if you could really consider needing leak dehiscence. Definitely. I don't see any of those issues because, again, this incision size is so much smaller. Intervention suture lysis, I mean, yes, you're going to pretty much have to do that for most of your Trab patients. So I don't know if I find that a pro or a con. And then bleb needling was higher with the Zen group. Again, I think as I've gotten better with my technique, and I'm sure it's not just me, but all of the community has gotten better. I think we're doing less and less needling. I find that I'm doing it just once in a great while now. And then this is our last one. I don't know how we are doing on time. Is In Focus micro shunt. In Focus is not available yet, but this is kind of the next iteration of a hybrid between tube shunt surgery and a Trab and a Zen. It's kind of an interesting combination. So really all you're doing is pushing this little tube that has a base plate in, and you're making a flap incision. So it's kind of got a similar feel to Zen, so that you can have more posterior flow, so that you have a larger, more diffuse bleb, which is, again, one of the nice things that we like about any of these. But you don't have the big base plate, which is, I don't know, again, a pro or con to the tube shunts. And so this, again, they tried to get it onto market. It is with Glaukos now. They didn't have a great study outcomes because they looked at it compared to traditional trabeculectomy surgery and didn't find it to be superior, or I think even at the same level as, so it's back to the drawing board. So unfortunately, this is being used in other countries really well and is becoming one of the favorites over Trabs and tubes, actually, is the next line, but we just don't have it here yet in the United States. So I think that's the end of slides. But just from a personal focus on kind of how I have been seeing MIGS, because I think my big question is when I talk to people is like, what's your paradigm? Does everyone have that kind of question of like, how do you figure out what you're doing when? Because there's so many different options that at this point it feels convoluted. And I oftentimes have my own colleagues that I work with are asking, like, what do you want me to put down in the chart about, am I overstepping to say, oh, I think they would be a great candidate for a Zen or whatever it might be. So first, and kind of how I look at minimally invasives is one, is if there's glaucoma, there should be a minimally invasive when there's cataract surgery done, right? I think at this point, we have way too much data to support anything but. So if you're working with surgeons who aren't doing these techniques, ask them why. Second, and this is a colleague to colleague discussion, and if it's not comfortable, it should be. And then you have to decide, what you want to do about that going forward with your patients, because ultimately you guys care for these patients, right? We operate on people and then we send them back. And that's the beauty of what I get to do, because that's how I like it. And you guys have to handhold afterwards, and especially have the discussion of why didn't something work? Why wasn't this tried, et cetera. And I've had to have those discussions too. And I think that feeling empowered to know that we rely on you just as much as you rely on us, and to know that ultimately, again, you take the bulk of the patient care, I think is important. So I really appreciate when people are well versed in what we can do, and then also feel like this is important to them as well to get these things done for patients. So with that being said, again, glaucoma, any medicines, we should really be doing this. I don't think that there should be any other discussion at this point. And then you have to find the surgeon you're comfortable with and who is doing the MIGS that you like. And I think finding surgeons who feel comfortable knowing the breadth of knowledge of MIGS, right? Because unfortunately, some of us get stuck with the one thing. And so knowing that somebody's continuing to progress forward, because this is a rapidly growing field. And I think it's important to know that the person you're working with knows what's going on and is very passionate about continuing to grow that knowledge. Because again, I think with each iteration of what keeps coming out, I feel like I keep getting better at getting better and better results with less and less risk and complication and just happier patients. The other thing that I think when I'm looking at how I determine my MIGS is how many meds people are on. I find that we all know that people don't do great with taking their eye drops, right? They're great at taking them like the day before they see us. And then inexplicably their pressure is fine, but they're progressing on their fields. So glaucoma is a place where I feel that we need to become more surgically dominant with the disease than we used to be. So it's hard because it used to be, you're not taking your drops, I have to operate on you, right? Like this is like, you know, you're scolding them into operating. Now it's like, oh, I get to operate on you. This is exciting. And it's a very different discussion and a different way of talking to people about this disease that we've been taking care of for decades. So when we start to open the discussion about glaucoma and minimally invasive glaucoma surgery, I think it's so nice to be comfortable to know that, again, they're safe and they're really effective. And that, again, we're talking about 3/4 plus of patients who are getting a really good response with these techniques. And this is looking at just one individual device. So then when we talk about patients who are on multiple medicines or have not gotten control of their glaucoma, then we talk about using multiple of these MIGS together. And that's when I see an even higher rate of response than what we're talking about in any of these studies. So when I talk to all of my colleagues who see my post-ops, because again, I am blessed in a lot of ways to not have to see a lot of them anymore, right? As opposed to what it used to be. I'm seeing and hearing how many meds are getting shed off of these eyes, how much better their surfaces are looking, and just generally how much happier they are. And it's interesting too to see not only does the surface look better, but then the vision looks better, right? Anyone who's taking care of dry eye, which is all of us, knows that all of these medications have a lot of negative impact on the surface. And then we live, for us here in Arizona, and then everybody's dry already. So when we're compounding that with 3, 4 medications, I mean, these patients are miserable. They're walking in, their eyes are red, their surface is terrible, their lids look bad. And so if you can reverse that for them by offering some of these things, you will change a lot of lives. And maybe that sounds corny, but that's really how my practice has felt over the last several years. And it's been nice to also hear how gratifying it is for all the people that I work with around me. And then just to see patients happy and off of all this other stuff. So with that being said, I think I will stop yammering on and see what questions we have.
Thanks, Dr. Funke. Any questions in person? Anyone? Sure, Dr. Egger.
Yeah.
And the pressure is extremely low when you do a gold loops on them.
Yeah.
You can actually see the heart.
Sure.
Goes exactly to the heart. So it's very, very soft. It's not quite a hypotenuse. I had to figure out what that was.
Yes.
But is that a problem when you do low pressures? And have you seen glaucoma patients that have keratoconus? It seems to me like it's an advantage to have keratoconus. Okay.
You know what? You're right that I don't.
Can you repeat the question for the
Sure.
virtual people?
Yes. So we're just talking about patients who have keratoconus. And if we think that there's some advantage to having keratoconus and kind of preventing glaucoma, I don't know if there's no study that comes to my head, but I can tell you from my clinic, the only ones I see is after they've had their corneal replaced. Then they come to me because then they have glaucoma. But you're right. I don't see a lot of patients who just have frank keratoconus, and those who do that have had one. I can think of one young man in particular that he's had one replacement of his cornea, and that eye has the glaucoma, and the fellow eye doesn't. So I don't know if that means anything to any of us, but I can say that definitely after the transplant, high risk of glaucoma.
Not just asking the question.
Yeah.
When you do if you do cataract on keratoconus with the low pressure that it is, and they're affected by stress, okay, big time. When they're real stressed out, cornea, at this distance.
Mhm.
Is that a problem figuring out what the power should be?
So we're talking now about powers of IOLs for keratoconic patients. Yes, cornea patients generally are going to be a lot more challenging. A lot of times I get multiple measurements for those patients. I'll make them come in a couple times sometimes. And I also have there's a hard discussion of like, we're not perfect. And I think when we talk to patients generally, I think setting correct expectations is so important when it comes to what I do with minimally invasives, when it comes to IOL planning, because of course I also do just standard cataract surgery. I do all the high-end lenses, which everyone has many high expectations. And I think that telling people these measurements aren't perfect. I am a person and a surgeon, but I am not perfect. And so we will do everything to get you as close to what you want as I can. But there's no guarantees. There might be glasses. There might be some kind of augmentation you need. So I think if you can be as open and honest with people about your abilities and also what limitations we all have as humans, I think that goes a long way. And I think that kind of patient is just that kind of person. Same with the post-RK patients. There's a lot of discussion there. Same with the post-LASIK patients. A lot of discussion there. I do like to use lenses that have an extended range of focus for these patients. I find that extended range of focus has saved me so many times because I have found less need for any kind of R&R or any unhappy patients who are having some kind of strange myopic or hyperopic surprise, because I think you're getting enough of a range in there that you can mitigate a lot of those issues. So that's where I've been starting to go with these patients. One, again, honesty, just honesty, brutal honesty that their eye is not healthy. It's not normal. And you can say the same things for the retina patients. You can say the same things for all the glaucoma patients, right? These things are the things that are wrong. I sometimes like to list them on my hand because sometimes they forget you have dry eye, right? And the dry eye post-op is a problem. You have an abnormal cornea, you have an abnormal retina, you've got this much glaucoma. I show them their fields because so often after cataract surgery and after everything they've heard from all their 100 friends who've had cataract surgery, they are disappointed in the results, even if you're so happy with the results. So I think setting expectations for a patient like that and also trying to do the best you can, as many measurements as you can, and using a lens that would be more appropriate to try and mitigate that is all the things I would do with it.
Excellent. We do have a lot of questions that came in online. Dr. Funke, is the iStent inject the same thing as G2?
Yes.
Okay, great.
There's a lot of names for the same thing.
If a patient has open angle glaucoma and you could use a MIG, do you have to meet the same requirements for cataract surgery to have insurance pay for cataract surgery and MIGS?
Oh, that's a great question. So that's a hairy one. It depends on the patient. I definitely have had patients who there's no cataract. If there's no cataract, I cannot take out their cataract. So then I can do Omni or some other canaloplasty goniotomy. Again, the triple iStent is something that we can also start using now. So there's other techniques, Zen. Those all are things that I still have in my bag of tricks that I can do with leaving their cataract in place. Annoyingly, after I do the surgery, of course, they're going to get a cataract because I did surgery in the eye. So then I have to take out the cataract. So that being said, though, no, if it's that case. I will sometimes take out patients. So one, if they can glare, even if it's like the vision's 20/25, 20/30, again, not my favorite for the cataract. And I tell them that too. I say, this is not for your cataract, right? We're doing it because it's in my way. And we're doing it because I'm going to make it worse. And we're doing it because you have enough glare that I can get it in under standards. But really, we're doing this surgery because I want to get these things in that I can't do without the cataract as well. And then also sometimes for my patients, I see a lot of hyperopic eyes. And so for those patients, that's easy because it's phacomorphic. And so really the cataract is, if it's in my way to a place where I can see the angles open enough, but I really wouldn't be comfortable getting access to it by doing things, then I'll take the cataract out prematurely. But can you just say, no, I want the cataract out now? No, not yet. Okay. Even though we should.
Yeah.
I think we're getting to a place where we know how beneficial that is to a lot of patients, but no, it's not standard of care.
Okay. Thank you.
Mm-hmm.
For patients that already have undergone MIGS, can they upgrade later to another MIGS?
Yes. So That's a great question too. So I have taken care of a lot of patients who have had the first iteration iStent initial, or even have had 2 stents placed. And I have gone in, definitely done canaloplasty. I go in behind the stents. I don't even have to move them. So they stay 90% of the time. Every once in a while I'll pop out. I could probably push it back in, or I'll just take it out. It just depends. So canaloplasty is a definite go. Goniotomy, if you're going to do that, of course, you're going to have to take the stents out first. I tend to like to just clean it out. One thing I didn't put on this that I've been using more is also with my standalone canaloplasties or canaloplasty partial goniotomy, I'll also use a little micropulse. So that's laser that's similar to diode, but a lot less intense. And I'll do just a part of the eye. So that shrinks back the ciliary body. So this little bit of shrinking back the ciliary body plus cleaning out the drain seems to work really well. And that's another thing that you can do with somebody else of already having had other stents placed. I've also placed a HYDRUS behind iStents, and I left the stent and then I put another stent and I just stacked them.
Excellent. Why can't someone with severe glaucoma get a HYDRUS?
It's FDA, nothing else. So the studies that were done, they only looked at mild to moderate patients. It has nothing to do with the actual efficacy of patients who have severe. Actually, patients with severe do just as well with all of these techniques as anything else. It's a coding issue.
So if someone wanted to pay out of pocket, they could do that.
And same with standalone. So I've had patients pay out of pocket to have a HYDRUS standalone in conjunction with an Omni because that they want as many things done at one time as they can. And yes, they can. Yeah.
Great. When should ODs refer for MIGS compared to managing patients with drops?
Oh, that's a good question too. So again, I think we need to be more proactive in terms of treating patients more early, generally with all these techniques. Again, first line SLT, I'm a huge fan. Again, if you haven't seen the light study, which I already mentioned a little bit, take a peek at it. But basically the light study is showing in a huge multi-center trial. And now in Europe, this is standard of care first line. You cannot do drops. You have to do SLT. And it's because SLT works so much better first. And it's amazing how much better it worked instead of in conjunction with drops. And I've always seen that. And so I think that if it's my own eye, and that's what I always like to go back to is like, if this was my own eye and my own body, what would I want first? I wouldn't want to drop. We know that there's so many negative side effects. I'd love to say we could all get drops that are preservative free, but we can't. That's the insurance world. And so because all those preservatives have such a negative impact over many years on the trabecular meshwork, we know we're actually harming their disease by treating their disease. And that's not the same with SLT. That's not the same with all these minimally invasives. So I encourage all of, so I'm in a large, I don't know if I said I was at Barnett, Delaney Perkins, and also at Southwest Eye Care here in the Phoenix area. And for us, we have a lot of in-house optometrists, which is great. I also see external referrals. And I just say, just send it to me. Just send it to me and I will take care of whatever needs to be done. And then I will send it back. My clinic, I try to keep as surgically relevant to me as I can, because that's where I can make the most impact. You guys are all extremely smart and great at what you do. You guys can handle the rest of that stuff. So if you have somebody who's ready for treatment, give them both options and push them towards the SLT. I think that it's the best way to go. It's how I would go. And I always tell patients that too. And so I think having a good relationship with whoever you're referring and knowing that that's what their practice patterns are. And if they align with yours, I think that's a really nice, easy way to do it. So for SLT, that's a quick, easy, just send them right away. As to MIGS, again, if they're ready for a cataract, please send them to a MIGS surgeon. Like, please. I'm just, I'm saddened by the patients who walk in my door and they just had cataract surgery within a year or two and they have nothing. It's depressing. And then to have that discussion is even more depressing because they want to know why. And, that's awkward. So make sure that, you have the reins on a lot of this. You all have the ability to tell people where they're going to go and who they're going to be operated on. So, you get to know all the people in the community and figure out what they're up to and then make that educated decision so that they can get the best care that they want. And so for anybody who's got a cataract, they should be going to somebody. And then if it's for somebody who's just needs maybe something different, I'm starting to get a lot more of those referrals for doing standalone MIGS. So they've already had their cataract out, but they're not that well controlled or they're advancing. Great patient for that. And it really doesn't matter what the pressure is because very honestly, again, compliance is a huge problem. and I've said it 700 times because that's what it is. It's a huge problem. And these jump over that problem. And again, we've gotten so much better with what we're doing that if we can eliminate that portion of the glaucoma care, I think we can do a much better job at keeping people from going blind.
Absolutely. Last question. How does an OD vet a surgeon without sending the surgeon patients and looking at the outcomes? Are there questions that we could be asking the surgeon or their practice?
Oh, that's a really hard question. I think one thing is, you know, you guys are all a community as well. This is a perfect kind of venue to talk about like who's out there, right? Who's out there and what is everyone seeing and what results are they getting? You can ask the surgeon directly. I mean, I wouldn't be offended. I think that they are offended. That might be like a nice red flag. And just, I think questions to ask are, what minimally invasives do you use? Why are you using what you're using? And how often are you seeing people get off medications or be better controlled post-op? And, you know, I talk to a lot of surgeons as part of my like side world, which I love doing. And I like asking hard questions. And there's a lot of silence and moments of awkwardness of like, why are you doing that? Is it working for you? And they're like, well, not really. I'm like, then why aren't you using something else that's better? And they're like, well, it's hard. Not probably a good answer for the patient, right? Like, well, I don't want to do the one that works better because it's harder. So, you know, I think asking people, you know, you don't have to be rude, right? But you can just say like, what are you using and why? I think you'll get a lot of information because you guys obviously all want to learn about this stuff and you understand what's out there. And so with the knowledge you have, then you can just see what they're doing and if it jives with what you want.
Excellent. Thank you so much,
My
Dr.
pleasure.
Funke. This was an amazing presentation.